have some people already on the call. So it's great to be back from summer. So we took a break for about a month. And I want to introduce Kiria, who I had the honor of being around a few surgeries with her. I think that was a couple of weeks ago, right, Kiria?
Yes, it was a couple of weeks ago.
Yeah, wow. Seemed so far.
Yeah.
So yeah. Um, so Kiria is a third-year resident. Tell us a little bit about yourself, Kiria.
Hi, good night. My name is Kiria Naomi Mayen. I'm actually from Belize. Like Dr. Hernandez said, I'm a third-year resident, currently at Hospital Rodolfo Robles. And I was there at Hospital de la Familia from the 1st to the 27th of July. Actually had a wonderful time there. I feel like I learned a lot. And well, I'm back to the city now. I started going again to the hospital here in Guatemala City. And well, some of my hobbies include going to the gym, which I was not doing a lot when I was back there in Nuevo Progreso. But thankfully, well, hopefully in the next couple of weeks, I'll be able to go back to my old gym rhythm.
All right. So you enjoyed being at Nuevo Progreso.
Yes, I did. I enjoyed it a lot. I feel like I learned a lot of things. I feel like the learning curve for people is like a bit different, and for me, it was a very good experience. It was really good being there on a daily basis and learning not only about the surgical cases, but also about the other cases that we had at the clinic.
Yeah, there's a lot. We saw a lot of things there. All right, Kiria, you want to take over?
Yes, sure.
All right.
So I wanted to start off my presentation with this line from Joseph Pulitzer. It says, put it before them briefly so they will read it, clearly so they will appreciate it, and picturesquely so they will remember it, and above all, accurately so they would be able to, so they will be guided by its light. So I just wanted to bring up this personality because he was like a person who was not only a figure in the sense of politics, journalism, publishing, and obviously there's a prize named after him. But there's a bit of history that he presented with high myopia and had an amblyopic eye. And he also suffered a retinal detachment in his better eye, which then caused him to become blind. He also had a central retinal artery occlusion in his amblyopic eye and had no light perception vision for the remainder of his life. Nonetheless, he was able to contribute a lot to journalism and publishing, and also to politics. So basically, my cases will be well, a bit similar to his cases, only that they had a very good outcome, really and truly. The author declares no conflicts of interest, and I'm going to start off with the first case. I have two cases to present. This first case is a male patient, 55 years old, from Tapachula, Chiapas, Mexico. He is a business owner. A bit about the patient's information. Well, he had a history of hypertension, under medication, no allergies, no trauma, and he had this in his personal ocular history. He stated that in 2015, he had sudden visual loss after drinking like some energizing drinks and doing some intense exercise. After which he was told that he had a retinal detachment in his left eye. And therefore, he underwent surgical intervention in 2015. This was in Mexico City. And he was told that he had a silicone oil taponade, but he did not improve his visual acuity. So he had gone to Hospital de la Familia on the 22nd of April, 2024, and he had an IOL placement in sulcus. And he presented to us already in pseudophakia to his left eye. And he had been really uncertain about the exact procedure that he had in Mexico. So for his chief complaint in his initial visit, he had a sudden decrease in visual acuity in the right eye now, since 1 week ago, with a slight right temporal headache. He had started to see dark lines and a dark spot, which abruptly increased in size. So on examination to the right eye, he had a hand movement visual acuity and a 2200 on his left eye. Basically on refraction, our auto refractor was not able to take his visual acuity on the right eye. He maintained IOPs of 10 in both eyes. On slit lamp examination, lids, lashes, and lacrimal system were normal in anatomy and contours on both eyes. Conjunctiva and sclera, white and quiet. Cornea was clear. Anterior chamber was deep. His pupils were reactive to light, isochoric. And well, the lens was clear on the right eye, and he had an IOL in place in sulcus on the left eye. When it came to the fundoscopic exam, on his right eye, we encountered a superior bullous rhematogenous retinal detachment. We were unable to determine if the macula was on or off because the bullous part was so protruding that it was covering the macular area. So we're not sure if there was subretinal fluid or if it was just the actual bullous detachment that had looked that way and was covering our view of the macula. He had a superior horseshoe tear and a superior temporal operculated hole detected, and well, the inferior retina was attached. And he had a PVR of B, estimated to be like that. On the left eye, he had his retina attached with no areas of elevation. The optic disc was sharp, margins normal in color, and a central cup with adequate cup to disc ratio. And the macula was slightly pigmented, and we noticed a pigmented tear enclosed by laser marks in his superior temporal area. So this is a picture that we took. Well, basically, we were not able to take fundus pictures at that point in time, but we were able to, well, draw. I drew this little picture of what it basically looked like. And we see right here, well, the bullous detachment itself, and we see what appeared to be the horseshoe tear. And well, right here, we don't have exactly the percolated hole, but it was basically over to this side. We're going to see it in different drawings later on. As his diagnosis, we had a rhematogenous retinal detachment on his right eye. And due to the location of the defects, we decided to carry out a pneumatic retinopexy with sulfur hexafluoride gas. We added ocular TID on that right eye and moxifloxacin QID to that right eye. So the procedure was carried out successfully. And 24 hours after the procedure, his visual acuity improved to 20/80. His IOP was at 12. And on the fundoscopic exam, we saw the retina attached with slight superior temporal elevation. Superior gas bubbles, there were 2. A horseshoe tear and the operculated hole were visible a little bit more. And we were able to notice now the optic disc, which was with sharp margins, normally colored, central cup, and the macula was on at that point in time. We were unable to carry out the focal laser at this point in time due to the fact that there was still a bit of subretinal fluid on that temporal area. So 72 hours after the procedure, visual acuity improved even more to 20/40, IOP remained at 12. And here, we tried to carry out the focal laser. We had made a few marks on the retina itself, but because there was still a bit of fluid, we decided to keep an eye on the patient. And even though we were able to mark a few areas, there was a bit of a barricade done to enclose the subretinal fluid and to maintain that part of the retina that was already reattached, well, basically in place. The issue we had with the patient was that, well, we're here in Nuevo Progreso, San Marcos, and the patient was from Tapachula, Mexico. So we noticed that there was a difference in altitude from Nuevo Progreso to Tapachula. And basically in Nuevo Progreso, we're at an altitude of 647.5 meters, while in Tapachula, it decreases to 161.40 meters. So due to the altitude changes, we noticed that the bubble had disappeared. Well, as the altitude decreases, there is like an atmospheric pressure increase and changes. So the gas bubble inside the eye will basically start to contract. under this low pressure compared to the initial state. So we noticed that the bubble itself, the two bubbles that we initially had, basically disappeared. And he came on his fourth visit with a visual acuity of count fingers, an IOP in 10. On slit lamp, there were no changes, but again, we encountered a superior temporal bullous retinal detachment. There were no gas bubbles, they had all disappeared. The horseshoe tear and the percolated hole were still there. We're not able to see our laser marks. So at this point in time, we already had Dr. Mateo with us. So she was able to take a look at the patient, and we decided to carry out a second pneumatic retinopexy. So for this, we were able to carry out the focal laser on the following day. Here we have a list of how the visual acuities were according to what we were doing, the procedures that we were doing. So he came on the 12th with a count finger visual acuity. We carried out here the second pneumatic retinopexy. And on the 13th, we were able to carry out a bit of focal laser where we're trying to extend the barricade because it was very hard for us to do it. Even though the subretinal fluid had decreased, we still had like a bit enclosing that area where we had the tear and the operculated hole. So it was a bit difficult to carry out the focal laser. So on the 15th, we put a bit more of the gas because it just kept decreasing in size instead of expanding. And we had a 20/40 visual acuity at that point in time. We carried out another bubble on the 19th because of the same issue. And at this point in time, we decided to hospitalize the patient and keep him right there at admissions at the general ward so that we were able to manage how that bubble behaved. And we were able to carry out on the 20th a bit more of focal laser. So this is basically how we kept the patient, and we had instructions written down on the chart so as to keep his position. And with the help of Dr. Isa, because I wasn't so well familiarized with carrying out the indirect focal laser, so she was able to help me out instead of doing it on the slit lamp itself. We were able to be carrying it out this way. So here's a video of me trying to carry out the laser and enclosing the defects. This was actually a new thing to me. I was able to do something that I didn't carry out here in my hospital, which was carrying out this kind of laser procedures. I was just basically doing it on the argon laser and the slit lamp. And I was able to enclose a bit more of the area with the help of Dr. Mateo, who basically continued doing so. And on his last visit, which was on the 26th, after we had completed his laser, he had a visual acuity of 20/40, an IOP of 10. The retina was attached with no areas of elevation. The optics disc with sharp margins, normal in color. We were able to see the macula on, and the superior temporal horseshoe tear and operculated hole were enclosed in laser marks. And this is basically a picture of what we had left. We're able to close the defects, and this is the barricade that we had done previously in order to try to minimize the passing of the subretinal fluid into the macular area. So the patient was very happy with his 20/40 visual acuity. Well, coming from count fingers and a hand movement to a 20/40 was actually really, really good. The second case is pretty similar. We had another male patient, 51 years old, also from Tapachula, also a business owner. He came in with chronic illnesses denied, no allergies, no trauma. He was pseudophakic in both eyes. He had a history with us there at Hospital de la Familia with pterygium excision on the 24th of August 2022, and he had M6 carried out on the 16th and 17th of April. So he was there basically for his follow-up visits, and he came exactly at a point in time when we were able to evaluate him, and it was some days after our initial patient. So as soon as we saw him, we more or less had an idea of what to carry out with the patient. He also had sudden decrease in visual acuity in the right eye. He had a bit more time of evolution since like 2 weeks ago, slight on and off ocular pain. And he said he started to see an amber spot, which increased inside, becoming a large amber colored shadow. He had hand movement, visual acuity on that side, and a 20/26 on the other eye. We were not able to take, with our auto factor, we were not able to actually get a reading. And he had an IOP of 14 and an IOP of 16 in the left eye. Basically, on the slit lamp exam, the anterior segment was normal, and the only differences that we saw were that he had his IOL in place in both eyes. But all the rest of the slit lamp examination was basically normal. When it came to the fundoscopic exam, on the right eye, he had a bullous retinal detachment. Again, we were unable to determine if the macula was on or off because the bullous area was covering the macular area. And he had a superior temporal horseshoe tear and superior hole detected on that area of the retina, and the inferior retina seemed attached. The problem with this patient was that he had a lot of vitreous haze. Like, we were not able to determine if it was more of a PVRC2 or if it was just the vitreous that was different and very hazy in this patient. Meanwhile, on the left eye, he had his retina attached with no areas of elevation, but we were able to find some superior lattice degeneration and slightly pigmented holes. So at that point in time, this is the drawing that we have of the patient, and we did the focal laser on the left eye where he had the defects, and on the right eye, well, we decided to look a bit deeper to see the defects, which are these two here. We see the bullous retinal detachment covering the macular area. So with our diagnosis, we have that rheumatogenic retinal detachment on the right eye. And we decided to carry out also the pneumatic retinopexy with the sulfur hexafluoride gas. We did the focal laser on the left eye because of his lattice degenerations and his pigmented holes. We left him with ocular TID in both eyes after the laser and the pneumatic retinoplexy and moxifloxacin QID in the right eye. 24 hours after the procedure, his visual acuity remained at hand movement, and we had an IOP of 16. We only continued to notice the inferior retina attached. We still saw that bullous elevation. We had a single superior gas bubble, and the horseshoe tear and the superior hole were also seen, but we had a lot of vitreous opacity. We had like a 3+ vitreous opacity. At that time, we called Dr. Mateo, and we told her about the patient so as to see what would be the management in this case. So we spoke to her and we said, well, this patient did not seem to improve, even though the gas expansion time was not up yet. We still had a bit more hours, up to 36 hours, but we did not see much of a difference even after the bubble placement. So we spoke to her and she said, well, maybe we can do a bit of a deeper surgical management with this patient. And we gave him an appointment on the 19th of July to be seen by Dr. Amatul to probably carry out a scleral buckling with a vitrectomy and the laser, the drainage of the subretinal fluid, and the silicone tamponade for that eye. Because, well, due to the vitreous haze and all of that, we thought the retina was not going to be reattached. Fortunately, well, when he came for his surgical day, which was on the 19th, he was seen with a visual acuity of 20/80, an IOP of 16, and the retina was, well, it was attached. It was something very, very nice because the retina was in place. He had a single superior gas bubble. The tears were easily seen. There was still a lot of the vitreous haze, but they were able to carry out his focal laser. So with him, similarly, we carried out the focal laser on that same day. We added another bubble because the one that he had was very small. So we wanted to extract a bit more of that subretinal fluid with another bubble. And what we had learned from
Buen inglés eso. Yo soy beliceña.
we had told about we had seen what the other patient had well, what happened to the bubble with the other patient. So we decided to keep him in hospital to just guarantee that he had the adequate head positioning and that we did not have the bubble contracting again and disappearing before the subretinal fluid was extracted. So on the 21st, we carried out another focal laser to continue to enclose the defects that he had. And on his last visit, he had a visual acuity of 20/80, an IOP of 14, and we were able to have that retina attached with no areas of elevation. The optic disc was with sharp margins, normal in color, central cup, the adequate cup to disc ratio, and thankfully, we were able to enclose completely the horseshoe tear and the superior hole that the patient had. And this is basically the last picture that we had, or the last drawing that we took from the visit, the final visit that he had. So we were able to enclose those defects, and our retina was attached in place, no subretinal fluid, and our macula was on. The only thing with this patient was that he remained with that vitreous haze, that vitreous opacity. And we told him that if everything was good, later on, maybe he would undergo another surgical procedure, which would basically be a vitrectomy to clear out a bit of that vitreous opacity that he had. So speaking a bit of the pneumatic retinopexy and overview, well, for half of the 20th century, the scleral buckling was the top treatment for retinal detachment with a 75 to 88% success rate. But there's like a lot of complications because of tissue trauma, high costs. Pars plana vitrectomy is now very common, especially for the pseudophakic eyes, like our second patient, but it's also expensive and increases cataract risk in other patients that are not pseudophakic. Pneumatic retinopexy is a less invasive, cost-effective outpatient option using intravitreal gas injection without incisions. And it is recommended for selected patients. But later on, I brought an article that talks about a little bit more about different uses of the pneumatic retinopexy in those patients that are not quite meeting the criteria for a traditional pneumatic retinopexy. In 1911, well, this is just a basic history. Ohm performed the first intravitreal air injection for retinal detachment. In 1938, we see Rosengren using intravitreal air with subretinal fluid drainage. Norton in 1973 used intravitreal sulfur hexafluoride. With scleral buckling or vitrectomy. Hilton and Gizzard were the ones that described the pneumatic retinopexy in 1985 using transconjunctival cryotherapy and gas injection. And the pneumatic retinopexy was validated in 1989 by a clinical trial with meta-analysis confirming high success rates. This is basically just an overview of the intraocular gases used. In our case, we use SF6, sulfur hexafluoride, which is the most commonly used gas in pneumatic retinopexy, which we use the 0.3 ml, and it has an average duration, 0.5 ml, with an average duration in the eye of 12 days and an expansion of the double in size in 36 hours. Like I said, the issues we had basically with our patients was the contraction of the bubble, secondary to the altitude changes that we had. Here's basically some cases to exclude from retinal detachment. Detached breaks larger than 1 hour, 1 clock hour, multiple breaks, detached breaks in the inferior 4 clock hours, a PVR grade C or D, physical disability or incompetence, especially when we're trying to have a specific positioning of the head to remove that subretinal fluid, severe or uncontrolled glaucoma, and clouded media preventing full retinal assessment. And this is basically a bit of the case selection that we actually had to keep in mind, including the extent of the breaks, if we had inferior breaks or not, the grades of the proliferative vitreoretinopathy, the inability to maintain the positioning of the head, and the glaucoma, which is basically the cases to exclude that I had mentioned before. This is just an overview of the procedure using the anesthetic. In this case, we did not use cryopexy. We rather used the focal laser to cover the tears the next day or when the retina is reattached. We tried the next day in both of our patients, but due to the presence of the subretinal fluid that we had, it was very difficult for us to enclose both defects initially, and we had to recur to putting more of the bubbles to be able to remove most of the liquid and then the fluid, and then we're able on different sessions to enclose the defects. This is basically an extract from the Ryan's retina, basically showing us the procedure itself of the pneumatic retinopexy with the injection. We were so lucky to have the gas available already there at Hospital de la Familia, because it's something that whenever we see a patient come in with all these criteria, and even without all the criteria for carrying out a normal pneumatic retinopexy, we're able to protect a bit more our macula, which brings us to this article by Dr. Jessie Jung, which is basically speaking about the anatomic, visual, and financial outcomes for traditional and non-traditional primary pneumatic retinopexy for retinal detachment. Our second case was a bit on the non-traditional side because of that vitreous opacity that the patient had, which made us believe in the first instance that he needed another surgical intervention to ensure that his retina was reattached. So now we include a broader range of retinal detachments, such as those with multiple quadrants, larger breaks, moderate proliferative vitreoretinopathy, and studies show that PR failure is often corrected with just one additional operation, achieving a high final success rate of 99.2%. Previous research has involved multiple surgeons, potentially introducing variability, but no long-term studies by a single surgeon have been conducted. And this study was basically to assess different, like a broader range of retinal detachments and decide whether or not it was effective to carry out a pneumatic retinopexy. And basically in the setting that we have at Hospital de la Familia, well, with Dr. Mateo just coming in like once, well, during a week period of time, a period of time of a week, every month, whenever we encounter these patients with the retinal detachments, we're able to protect their macula a bit more until the time that she arrives, and we're able to carry out a second surgical procedure. So when it comes to anatomical outcomes, the PR is effective for a wide range of retinal detachments, including those with large or multiple breaks in some cases of the PVR. Like I said, after additional interventions, if they're needed, 99.2% of success rate. The visual outcomes for both traditional and non-traditional show strong visual results. The success rates in maintaining or improving the visual acuity are comparable between the two approaches. And non-traditional PR cases have demonstrated effective management of more complex detachments without compromising the visual outcomes. When it comes to financial outcomes, it's cost-effective compared to other surgical options like scleral buckling or vitrectomy. And cost analysis indicates that there are significant savings with carrying out a PR, particularly in these non-traditional cases where fewer surgeries will be required. And long-term considerations, well, we need to see a bit more of future studies in order to compare all these indications. But with this article, we're able to more or less determine that even if we have a non-traditional retinal detachment, if we have multiple breaks, if we have a bit more of that vitreous opacity that is making us unable to determine, or if the bolus detachment is a bit big that it's unable to determine whether macula is on or off, we can still carry out the procedure itself. So that is basically what I brought tonight for you guys. Thank you so much for paying attention. I know it was a bit like long, but I hope that you're able to enjoy the two cases that I presented.
Kiria, that was really a great presentation. Wow. Great cases, well managed, especially I'm really happy that you were able to do that by yourself. That was really cool. And it's also, it makes sense to do this because it's it's cheaper for a hospital and you're protecting the macula of these patients. And if they ever need vitrectomy, it is available in the hospital now. So we're really happy that you were able to do that for those patients.
Yes, it was really great. It was a great experience. I had done some pneumatic retinopexy here at Rodolfo Robles before going, but obviously, I had the help of the other the fellows there that were with me at all times, and also being on the phone with Dr. Mateo and also with Dr. Teresa for the first patient. But she was there during that week, which was awesome because she was like, okay, she checked the patient and she said, oh, well, we can add another bubble. We just have to ensure that all the subretinal fluid comes out and we need to do the laser. And the patients, they were really involved in their cases and they were very conscious of keeping their head positioning. Even though they were from far, they decided to stay because they saw an improvement from the point to the point that they were able to say, okay, I'm going to stay in order to ensure that the bubble stays in place and that I continue with my improved visual acuity. So it was like, it was a group work that we did.
It's always a team effort.
Yeah, it was a huge team effort.
Yeah.
I thought those were amazing cases, the way you managed it. I'm super impressed. I was just wondering, I'm always super interested in history, particularly really innovative treatments like this. I was wondering if maybe Dr. Sorensen could comment on the inventor or developer of this procedure.
Pneumatic retinopexy.
Yeah, didn't you know Dr. Hinton?
Yeah, Dr. Hilton.
Hilton,
Yeah,
that's it. Dr. Hilton.
Yeah.
Yes.
Yeah. I mean, it is an interesting bit of history that Dr. George Hilton was an ophthalmologist here in Berkeley. He was actually an optometrist first and then went back and got his MD degree and trained in retina, and in the Bay Area pioneered this idea of pneumatic retinopexy. So he's probably for 2 or 3 decades was teaching people worldwide that technique. And then I think once the sclerobuckle kind of came along, he that kind of took over most of the cases. Yeah, Dr. Brinton, then his progeny is Dr. Hilton, and then Dr. Brinton, and then Dr. Brinton hired Soraya and Jesse. So that's the genealogy of pneumatic retinopexy. I do have one question though. I was surprised how that first case detached so many times, and then you said the bubble disappeared, and I was wondering if you could comment, because I wouldn't expect the SF6 to dissipate unless it went through a wound, right? I was wondering what happened to that.
Yes, so I was trying to find a bit more articles because there are more articles on the expansion of the bubble itself and the IOP increases, but we did not have a wound for the gas itself to be leaking out of. So we decided to look into the fact that there were altitude changes that were maybe trying to do something with the biomechanics of the gas, I would like to say, because the patient had the gas bubbles. We did not have any fish eggs, or we had one large gas bubble, a small little one next to it, and the gas, it was there. And the subretinal fluid was still a bit present around the defects. So we decided to wait for the gas expansion to carry out the laser, but when he returned, there was no gas. And basically what we did with adding a bit more of the gas to that patient was to try to push the gas expansion to occur and for the subretinal fluid to come out. But for some reason, I also thought about it and thought that maybe it was leaking from somewhere, but we weren't able to determine where it was leaking from a wound or something, but the patient did not have any. So we had to attribute maybe to the difference in altitude, but it was very curious that the fact that we had to place on multiple occasions a gas for the liquid itself, for the subretinal fluid to be completely removed, and so that we could apply the laser.
And it's interesting that when you hospitalized the second patient,
yes,
that didn't happen.
That didn't happen. So the only difference was that basically he was traveling on a daily basis from San Marcos to Tapachula, and there's that altitude difference. But apart from that, we did not have a wound leaking that would explain the fact that the gas was disappearing. So once we decided to keep him in hospital is when we were able to carry out a better laser and having most of the liquid, the subretinal fluid, come out so that we would be able to enclose the defects properly.
We have had some patients that come from Sheila, and they travel to the city, and when they have something like this done, we really want them to stay in the city for at least a week. We don't want them either traveling through the south or going up the mountains, because that can cause high pressures, or going down, it can cause the bubble to shrink and have another retinal detachment. We have seen that.
Yes. So that's what we basically started to think about the altitude changes when it came to that.
Here's a question. When is cryo preferred to laser? Were you able to read that, Kiria?
Basically, well, generally what we saw here when it came to the procedure itself was that we can carry out the cryopexy when it's in a one session procedure. So if we can have the patient stay there and we carry out we have someone present to carry out the cryopexy, first of all, and we're able to detect these retinal tears, do the indentation, and carry it out. We can do it in a one session. We can have the patient there, carry out the cryopexy, and include the gas, the application of the gas, the intravitreal gas. So that's when we have a one session procedure. Meanwhile, if we go into carrying out the focal laser, that would be after the retina is reattached, in case we don't have the cryopexy. But generally, when it comes to the description of the procedure itself, the cryopexy is preferred for the single session procedure, which would be the carrying out a traditional PR. In our case, in our settings, because we did not have our retinologist there and we were not able to carry out the cryopexy at that point in time, then we did the two sessions or the multiple sessions procedure, which included the laser after the intravitreal gas injection.
So I'm not a retina specialist, but my dad did train with Ed Norton, and he does cryo whenever he can't see the vision or the visualization of the hole is very difficult.
Okay.
So he goes in and he does cryo, and then sometimes after the cryo, he may inject, or he chooses to go one first and then the other, depending on visualization. Really, that was his criteria.
Okay.
Rupert, do you have a question?
I just want to make a comment about how these two cases, great job, by the way, really highlight the progress at Nuevo Progreso. Many of us who've been there many, many times recall, sadly, how many times we had to send these detachment patients to Guatemala City. Very unlikely they ever went. And so to see these two cases and the success just highlights the positive movement. And Andy, your work in this and everyone else has been remarkable. It must make your heart soar to hear these cases. I'm really reminded of the progress and how wonderful this is to hear and to see, in light of how many hundreds of patients we had to send away for years and years and years. So my hat's off to everybody who made retina happen.
Yep. Amazing.
Yeah.
All right. Great, Kiria. Great case. Is really great discussion. I think we are really pleased with. I was there with you during the surgeries, and I'm really pleased with your work. And keep on the good work that you're doing at Robles. And thank you for the presentation. It was really, really enlightening. And as Rupert said, it really showcases how retina has grown in the few months that's been working. So if there's any other comment, Andy, Rupert, anyone? If not, then you can all go to dinner.
Thanks, everybody. Excellent.
Right.
Gracias.
We'll see you next week. All right. Thanks.
Thank you.
Thank you all.
you.